Chemotherapy for ovarian cancer. Whether you're getting chemotherapy after surgery or your treatment started with chemotherapy, if you don't know which one of these two you'll be getting, watch my video comparing the neoadjuvant chemotherapy where chemo is given before surgery compared to primary debulking surgery followed by chemo. That video explains some of the reasons why care providers of ovarian cancer choose one over the other based on the patient and cancer characteristics. Regardless, the combination of carboplatin and paclitaxel, also known as Taxol, is what is most often prescribed in this cancer. Now, these two drugs can be given in many different ways, but I'm going to talk about the most commonly used regimen where both of these drugs are given together on the same day. Let's call this day one. The patient usually comes in for the infusion. They are seen by the provider just to make sure their lab work, their blood counts, liver function tests, kidney function tests, and general health is in good shape. They are not experiencing any illness or an infection. Once you're cleared from the chemotherapy, a patient is usually sent for infusion in the infusion center. Once you receive the chemotherapy on day one, nothing happens for the next 3 weeks. And then this same chemotherapy is repeated on, this will be the day one of this cycle, but this is cycle 2. This is cycle 1. So this is 21 days in between these two treatments, or 3 weeks. So you can see cycle 1, cycle 2, and so on and so forth, depending on the number of cycles the patient is scheduled to get. Very often, when chemotherapy is given before surgery, they are usually 3 to 4 cycles. And when chemo is given after surgery, there's 3 to 4 cycles in this setting when the surgery happens and then chemo. So that's 3 to 4 cycles. When surgery happens first and then chemo, all of it happens afterwards. Usually this is 6 to 8 cycles. More often than not, it's 6. So that's how the flow of the chemotherapy works. Now, these 3 weeks can be divided into 3 different weeks. So let's think about the week 1, week 2, and week 3. So week 1, week 2, and week 3. This first week, fatigue and nausea are the most common symptoms. This is where the chemotherapy is starting to work on killing some of the rapidly dividing cells, including the cancer cells, but it's also killing some normal cells, and that's why the blood counts start to fall very rapidly. But then in week number 2, this is where your fatigue and nausea is better, but the blood counts are really low, so there's an increased risk of infections. In some instances, there's also an increased risk of bleeding because one of the components of the blood called platelets, which is very important for formation of clots, goes down in this time frame anywhere between day 10 to day 14. So there's increased risk of infections, increased risk of bleeding, and then these counts start to get better. Week 3, you start to feel normal. I'll say in quotes because this is a new normal. At least you start to feel yourself a little bit, and then cycle 2 is ready for you. So this goes on for the number of cycles which are scheduled for the patient. Now, in some instances, if the blood counts don't recover, the providers will push the chemo back by a week. That happens very frequently, and if that happens, there's no need to panic. It's just that your bone marrow is taking a little bit longer to recover. It happens fairly frequently and doesn't make a difference in terms of the treatment. You just come back a week later and get the treatment as scheduled. But the blood counts have to be above a threshold for us to give the chemotherapy, because if you start at a very low level, then you can enter some really dangerous territories where bleeding can become spontaneous or the infections can become really problematic. So let's talk about the side effects in addition to what I've already talked about for these drugs. So I'm going to write some side effects in the middle, and these are something which is common to both of these drugs. As a matter of fact, they're common to many chemotherapy drugs. So increased risk of infections, as we discussed already. There's increased risk of bleeding. There's increased chances of anemia. Now, all 3 of these things is the direct result of the chemotherapy being very toxic to the bone marrow, where rapidly these cells are being produced in human body. Chemotherapy doesn't know the difference between These cells are cancer cells or no cancer cells, but they get targeted by the chemotherapy because they are dividing rapidly. Hair loss, same rationale. Now, hair loss is implicated to Taxol way more than it is to carboplatin. It just happens to be different for every chemotherapy, and it depends on what we call as pharmacokinetics, which means what is the distribution of this drug. So wherever this drug goes more often, for example, around the hair follicle, Taxol accumulates in there. It's much more likely to lose. You're much more likely to lose hair when you're on Taxol as opposed to carboplatin, where thinning can happen, but you don't lose all your hair. Now, similarly, carboplatin is much more toxic to the bone marrow, whereas Taxol is somewhat toxic to the bone marrow, but not the difference is not as pronounced as it is in hair loss between the two drugs. Another side effect, which is more unique to Taxol and doesn't really exist in carboplatin, so I'll just write it in the Taxol column, is neuropathy. Taxol tends to accumulate in peripheral nerves where nerve cells are much more susceptible to the toxicity because of the mechanism of action of Taxol is by inhibiting microtubules. What's more important here is that the nerve cells do not have the ability to regenerate as quickly as some of the other cells in the human body. So this neuropathy, if left unchecked, can become permanent. Usually patients would start off with something like tingling sensation, which is quite frequent, numbness. So you have to tell your provider when you go for cycle number 2, 3, subsequently, as the sensation of tingling and numbness, if it's getting worse, if it's not coming back. What I mean by that is you feel that the tips of the finger are numb, but by the time you go for your next cycle of chemotherapy, they're somewhat back to normal. That is called reversible neuropathy. That's expected of Taxol. But if the numbness is not coming back, but it's actually going up the fingers towards your arm, then some dose modification or a change of Taxol to a different agent might be warranted, because if this neuropathy becomes permanent, that could be quite a bit of detriment to the quality of life. Now, this is a balance the providers have to achieve, where you want to be aggressive and give the full doses of chemotherapy to achieve remission and cure. But at the same time, in some instances, we have to be very careful because there are some other agents which are available, which are just as effective as Taxol. One of those agents is Taxotere, which is a cousin of Taxol. Both Taxol and Taxotere are trade names. The actual name for this drug is docetaxel. So these are some of the things which need to be discussed with the provider during each chemo cycle. So moving on, some of the other side effects are, we discussed previously, nausea and fatigue. These are very common to most of the chemotherapies, but carboplatin tends to be much more nausea-inducing compared to Taxol. Fatigue is multifactorial. It could be that the Taxol is irritating to the nerves and the muscles. That can cause a lot of pain, and myalgias is what we call it, which is pain in the muscle. All of that contributes to fatigue. When you're anemic and your blood levels are really low, that can contribute to anemia. Worsening of other medical problems can also lead to fatigue. So fatigue can be a real problem with chemotherapy, and the cause of this could be any one of these things which we've discussed. Some of the other side effects which are specific to carboplatin is it can be toxic to the kidneys. So that's the kidney toxicity. And then one other very common side effect of chemotherapy is diarrhea. Diarrhea is complicated for providers when that happens. Chemo by itself prevents, I think this is worth a conversation. If you look at the bowel, human bowel has lots of cells inside of it, but they're more like projections like this. They increase the surface area where the food is being absorbed. When somebody is getting chemotherapy, their bowel looks more like this. Many of these cells are obliterated by chemotherapy because they are also rapidly dividing. So the food just rushes right through the bowel and can cause, this chemotherapy can cause diarrhea. Any chemotherapy which is killing the rapidly dividing cells can cause diarrhea. But at the same time, why it is confusing for the providers and something which needs to be worked up and more investigations need to be done is because you're also susceptible to infection. So it could be infectious diarrhea. So this is a problem if diarrhea happens, especially during week 2 when the immune system is down, or if there are sick contacts in the household, could be related to infection. So infection workup needs to happen. But if that is not clearing up, or at least the diagnosis is not related to infection, and the providers give you some medications to slow down the bowel after ruling out that it's not an infection, then it could be some of the other problems with diarrhea could be more challenging. And that's something which Taxol does very rarely, fortunately, but when it happens, it can be very problematic. It's called Taxol colitis. This is intense inflammation of the colon, which is causing diarrhea. And in these instances, oftentimes steroids are necessary and the Taxol needs to be taken away. But this is a rare situation. More often, it's an infection or the fact that the chemotherapy has gotten rid of these villi inside of the bowel. So that's what's happening in most cases. There are many other side effects, and I'm not talking about the rare things. These are the most common things we talked about. One other side effect, which I think is worth noting, not technically a side effect, but something which happens with chemotherapy, is infusion-related issues. Now, these infusion-related issues can be divided into 2 different categories. The first category is just mechanical stuff. What I mean by mechanical is that you need an IV. These drugs are not oral. These are IV drugs. And the IV can be peripheral, meaning in the arm or the hand. These can sometimes leak, and the chemotherapy can go in the muscle area, and there's this collection and the swelling. This is an emergency. Luckily, this is very rare because the chemotherapy infusion nurses are trained to make sure that the IV is working very well. But if a patient has received multiple cycles of chemotherapy before, then this becomes a common problem because all the veins in the arm or arms have been damaged by the chemotherapy. Getting an IV access becomes a problem. In these cases, a port is necessary. And a port is this big IV. Imagine a big IV that is placed. So if this is the neck and the arm, the collarbone is over here. This is usually placed on the right side under the collarbone. And then there's a little bit of a tubing which connects into a big vein into the body. Oftentimes this is buried under the skin so nobody can see it. Some numbing cream placed over the port, and then port is accessed. This becomes very easy as compared to getting IV access, as we discussed, in somebody where access is difficult because of the veins have been damaged previously. But the port comes with its own problems. Infections is one of those problems, so the port has to be taken care of very carefully. Only providers who are certified in accessing the port should be allowed to access it. And then the second problem is sometimes that increases the risk of blood clots, because as you can imagine, this IV tubing is sitting in the blood and it irritates the inside lining of the blood vessels, increases the risk of blood clots in around this area. So your provider will make a decision based on the circumstances. Overall, I think the ports are fairly safe. The risk of complication is relatively low, and it's actually really, patients like it because you don't have to be poked for blood transfer, for blood work, or for IV placement for chemotherapy. The other side effects which are related to the infusion are something called as hypersensitivity reactions. This is just a fancy word of saying allergy. Now, allergy implies, so the reason why we don't use the word allergy is allergy implies as somebody has peanut allergy or allergy or some gluten allergy, that you had it and you were exposed to the substance and all of a sudden your body reacted to it. Hypersensitivity is a little more complicated than that. And it's different for Taxol, where it happens more or less like a peanut allergy, that the infusion goes in, patients feel flushed, and they feel like as if they're losing their bowel and bladder control. Sometimes they have shortness and chest pain. They feel like an elephant is sitting on their chest. All of these things immediately get better when they're given steroids. As a matter of fact, patients are given steroids before Taxol infusion to prevent these, but sometimes, despite the best efforts, steroids, Benadryl, Trazine, all of these drugs given prior to the infusion, these reactions can still happen. Now, in these cases, depending on the severity, the provider might decide that you can no longer get Taxol. In that case, there are some substitutes they'll do. Or they may decide that you need steroid prep, meaning you take steroids for 24 to 48 hours before coming in, and then you get a much bigger dose of steroid before Taxol, and the infusion is slowed down, so the drug is going into your body very slowly. So these maneuvers can actually make it possible to give Taxol to somebody who had a hypersensitivity reaction, provided it wasn't a life-threatening hypersensitivity. So any of these maneuvers are possible, and your provider will think about these and make some decisions based on that. Whereas the carboplatin hypersensitivity is slightly different. The more exposure you get to carboplatin, maybe somebody who's gotten 7-8 cycles, they tend to generally develop a hypersensitivity reaction, which appears like a allergic reaction. This is much more common at 6, 7, 8 cycles later instead of in the beginning. So these are the things which your provider should be keeping in mind, and you should be keeping in mind that during the infusion, if you feel funny, you should be calling your nurse right away. So because of this hypersensitivity reaction business, a lot of patients, as I already mentioned, will get a combination of steroids. They'll get Benadryl, and usually something like cetrizine or related drugs, and Pepsid. These are just some names of the drugs we use in our practice, but anything in this family where allergic reactions and hypersensitivity is prevented by that. One other big combination drug given during and after chemotherapy, which I haven't discussed yet, is nausea prevention. Now, nausea used to be a big problem with chemotherapy, and still is in some chemotherapies, but the drugs have dramatically improved in the last few years. So most patients actually do really well, and there's only a handful of patients where we have to add on more medications or do some other things to prevent nausea from happening. But most patients are nowadays either nausea-free, or nausea is not such a big issue as it used to be. Now there's a group of drugs which are being used now, and it's a combination given to patients. And in carboplatin and paclitaxel combination, patients often get the steroids. Now, steroids are doing two different things over here. One, they're preventing the allergy, as we discussed, but they're also very helpful in preventing nausea. Then there's a group of medications called NK1 inhibitors. This is an infusion which is given. Sometimes it's an oral drug, but this is usually goes by the name Amend is one of them, but there are several different one of them, including biosimilars and generics, which are available. And then patients also receive some very powerful drugs that block the signal for nausea and vomiting. These are called 5-HT3 blockers. The most commonly used one, the name you may have heard, is called Zofran. There are several of these on the market. Some of them are IV, some of them are oral, but this is something which patients are also given to take at home, and you'll get a good detailed explanation of how to take this on day 2, day 3, day 4 after your treatment. Now there's two other drugs which are frequently used. One is called olanzapine. Olanzapine is actually an antipsychotic medication when given at a much higher dose of something like 40 milligrams or so. But at 5 to 10 milligrams, this drug has been shown to be a very effective nausea medication. Most of the patients are told to take this drug at nighttime. HS means as nighttime, because one of the side effects of this drug is it causes drowsiness. So we often tell patients that if they're taking olanzapine at nighttime, they may want to make sure that there's somebody there to help them if they are getting up to go to the bathroom in the middle of the night, so they don't fall. So there's some issues with olanzapine, but the lower doses don't cause as much sleepiness as higher doses do, but still some caution is necessary. But these are very effective drugs and usually are given for 3 to 4 nights. And then there's something called as compazine. The actual name of this drug is prochlorperazine. This is also an antipsychotic drug when used at a higher doses, but lower doses, just like olanzapine, is very effective in nausea control. Typically, this is given to patients as what we call as breakthrough medication, meaning if none of the other medications are working, then patients will often take compazine as a backup method. Some of the fatigue, which I previously discussed, can be multifactorial. One factor which also increases the risk of fatigue is polypharmacy, which is basically all of these medications being given. And there's a good reason why these medications are being prescribed, but all of them together can increase the risk of patients feeling drowsy, fatigued, especially during that first week of chemotherapy. Now, there are some very good reasons that patients should be calling the physician's office, going to the emergency room in certain situations, and these are related to all the side effects we've been discussing. If somebody has fever, this needs to be reported right away. And a fever usually in this context is defined as a temperature of greater than 104 degrees Fahrenheit, which translates to about 38 degrees Celsius. So in this setting, this could be an infection. It could be that the patient's immune system is not doing well and becomes a life-threatening problem, and therefore this has to be taken very seriously. If the nausea and vomiting is becoming uncontrolled, especially the vomiting, this can cause a lot of imbalances in the electrolytes, especially potassium levels, which can be life-threatening. Bleeding of any sort, it's better to call and discuss. If it's heavy or if you feel any of this seems like an emergency, keep a low threshold of calling a 911 and figuring out what the next steps would be. If a patient suddenly starts to feel, short of breath, this could be a big problem. It could be related to anemia. It could be related to something which can be very life-threatening called blood clots. It could be related to the infusion reactions, or if neuropathy is becoming really, really problematic to a point where the patient is at a high risk of falling. These are important issues. The hypersensitivity issues usually will happen during infusion, but with carboplatin, as I discussed, when you've had several cycles of that drug, sometimes hypersensitivity can happen later. And there are some things we tell patients to do at home to reduce their risk of infections. Masking is effective. Staying away from patients who are sick, especially young children, especially during that second week when the immune system is not functioning as well. Cooking your food thoroughly and avoiding raw food. Wash the vegetables and the fruits thoroughly. Doing these things which are fairly common sense, hand hygiene, using a hand sanitizer when you're outside, and avoid crowded areas during that second week when your immune system is down. But in general, during chemotherapy, it's not a bad idea to avoid that. All of these things, not only they can be life-threatening, but then there's this issue when you get sick, you can't get the next cycle of chemo. That delays the chemo and can be problematic in terms of getting rid of the cancer in a timely fashion if your chemo is not given. Now, if patients are younger and they're getting these chemotherapy, sometimes issues about lactation and breastfeeding, that is, or contraception has to be discussed with the providers. So these are the issues I'm not getting into here. And going back, finally, I just realized I forgot to mention something very important. Many of these nausea medications, especially the 5-HT3 blockers, which includes Zofran, is constipation, one side effect. Now, this may sound like nothing, but what ends up happening is the constipation can get so severe that sometimes patients end up in the emergency room with abdominal pain, and they get a lot of workup, CAT scans, etc., just to find out that these medications were causing intense constipation. So keeping a bowel regimen, which you should discuss with your provider during the chemotherapy, is very, very important. So we've covered a lot in this video. Obviously, this is not medical advice. This is just for educational purposes. So when you go in and talk to your care team, you have some baseline knowledge. I'm sure they'll cover a lot more things which I may have missed. If I've missed something, I'll put a link under the video, and good luck.